All right, thank you. Those were all fantastic. So just a quick thing, I'm supposed to say that evaluations will automatically be made available for attendees within the OHBM app. Please assist our speakers by sharing your valuable feedback immediately after this session. So we'll be taking questions just for a few minutes, both on the mic and in the app. I'll just open with one that was asked quite a while ago to Sordob, which is that could you explain the physiological reason for the negative correlation between nose tip temperature and galvanic skin response?
So skin conductance is a purely sympathetic response. And the facial thermal imaging signal is a mix of both sympathetic and non-sympathetic. So I can't tell you at the neurophysiological level why the anti-correlation is, but at least with the autonomic system, there's a difference in the sympathetic and the parasympathetic. Maybe it is that one is capturing more of the parasympathetic, given that the skin conductance is only very sympathetic. So that might be one reason as to why they are negatively correlated. There are multiple studies which have shown this anti-correlation, but not to the extent, or at least in the deep dive of the neurophysiological sense. So that is how much I know about the anti-correlation. I wish I knew more.
Okay, great, thanks. And we'll take the question over here.
Thank you. My question is for Gaurav. So you showed that for silent movies in patients with schizophrenia, there's more correlation within V1 relative to controls, if I understood correctly. And I was wondering what your interpretation of that is, and also did you look into whether that correlated with hallucinations, because that's what came to my mind. Maybe that has to do with verbal auditory hallucinations.
Right. So I'm perfectly happy to hear ideas for interpretations. It's a little bit difficult to wrap our heads around. So far, what we've thought is that it seems to be just empirically, as I said, some kind of failure to appropriately segregate the processing streams or something like that, which may be mediated by the STS, but we haven't seen that correlation yet. Now, it might be because of our small sample size, but the the fact that we're doing group average imaging. In terms of the correlation with hallucinations, I don't know. I don't think Jessica's run that, or if she did, it was negative. But again, we do have a small sample size. And going back to the complicated thing about self-report measures like psychotic symptoms measures, they're kind of coarse and can be difficult to interpret. So maybe, I don't know, and if you've got ideas, I'm perfectly happy to hear them.
Thank you.
And we'll take a question over here.
Hi, thanks for this great symposium. Echoing. So inspired by the last great talk, I'd love to hear each of the speakers' perspectives on the sort of pros and cons of taking already made films, because you talked about the fact that, it's this industry that is masterful at creating evocative, emotionally, rich films. But when you're taking existing films, you've got challenges of, repeatability, familiarity, all these things, versus creating your own sort of bespoke film to tap into things. And so I'd love to hear sort of the pros and cons from each of your perspectives.
We'll let Tammy lead.
Yeah, and I mean, there are pros and cons. I think that's a good way of putting it. It's much quicker, much cheaper just to use something that's already in existence. And, if Hitchcock is going to direct something, I want to use that film for sure. There are copyright issues. It's been a big barrier in sharing stimuli, and that, I think, does hold back progress and holds back generalizability of our findings. There's also, so I think either way you do it, we only make the movies when we think we have to, like when there's something that isn't in existence and we think we actually have to make something to get what we want to answer our question. Otherwise, I would say I'm using films as much as possible. I do think validating the clips that you have chosen, making sure that they do what you think that they do in the participants that you are studying is super important. Yeah, I think it's something we're going to continue to grapple with as a field.
Yeah, we've grappled with that too. Some of the things that we've used previously that from other groups, not Tammy's films, but our concern has often been the quality of the script and the acting and even just the video quality itself. Or we do a lot of visual neuroscience stuff, and so having low video resolution really affects how well we can do things like face recognition and that kind of thing.
Yeah.
So we have generally veered towards Hollywood type productions, but those have disadvantages too. We don't control the content, and people may have seen them before, and they're also shot, professionally shot things. They're all shot to direct your attention somewhere in a way that's not necessarily super naturalistic. And I think Emily Finn and you probably have had pieces on this. So one way that we're going is now to start thinking about video games, and what can we accomplish with that for specific behavioral manipulations that we're interested in.
And I would also just add, I don't think we know that no one's collected the data set to really understand the effect of familiarity. You can use it as a covariate, so if you collect, like, how well did you know this movie before, that's a good idea. But my own opinion is that it's not whopping, but I could be wrong.
Just to add on Gaurav's point about the games, I was doing my postdoc in Cambridge, and there's Dr. Paul Fletcher over there, and he's developed a game for people with psychosis along with the gaming company. And most of the people who were suffering from psychosis, they really gelled, really felt that this really captured some of their feelings and everything. So gaming was definitely one way to go about it. Just about the pros and cons, one of the things, as Tammy said, not one film overall would be a broad spectrum film covering all the clinical realm. So for OCD, some of those frames and the scenarios would elicit some of the symptoms there, and you can test that in fMRI, but that might not be relevant as much for depression or for other illnesses. So then we'll need a suite of all different film clips. Also, as also Gaurav was saying, and in the symposium, in the educational course yesterday, I was showing some of this intersubject correlation analysis depends a lot on how the directorial style is for the movie. So Hitchcock's films just creates, they are so manipulative that most of the people feel very similar things. And as that goes away with other series like Curb Your Enthusiasm, which has a very freely directorial style, there's intersubject correlation decreases a lot. So if we are to also make films, then obviously there's so much investment and all the mastery that we have to learn to create such very nice films. So both pros and cons there.
All right, so we're out of time now. I see there's a lot more questions in the app. Feel free to come and talk to us afterwards. I want to say thank you for listening, but I just want to say one last thing, kind of ending on Tammy's talk. If any of you are thinking of using movies in terms of boosting the clinical relevance, please think about what you're actually showing and don't actually just throw any old movie in there. I think that's a popular
That's the
theme.
take-home.
I think that comes across quite a lot for us. But thank you all for coming along. It was great having you all here.
And thank you, Peter, for organizing.